everyone, welcome to my Day in the Life series here on White Coats and Corgis. Most of you probably know me from Instagram or TikTok, where I make helpful free content for pre-meds and talk about my journey as a first-generation medical student. My mission here on YouTube is to give pre-med students all the information they need for a career in medicine. So in order to do that, I've teamed up with MedSchoolCoach to create this series where I'm going to do a deep dive on each medical specialty. And I want to start off by saying that it can be really difficult to accumulate the number of shadowing hours you really need to be accepted into medical school. And especially nowadays, this can be really challenging. A lot of physicians aren't open to shadowing opportunities in person the way that they were before. So that is why MedSchoolCoach decided to collaborate with over 20 doctors to give you a behind-the-scenes look at practically every specialty that you might be interested in. And this is all completely free. You can go to shadowing.medschoolcoach.com, register for the program, and then you get to choose whichever specialties you're interested in to shadow. At the end, you can fill out a short quiz, and then they'll give you a certificate of completion. That way you can count these hours on your medical school application.
Great. So I will be presenting on dermatology as part of our MedSchoolCoach virtual clinical education series. Again, my name is Yusha Lajavardi. I have an MD, and the MA is for my master's, and what the FAAD means is Fellow of the American Academy of Dermatology, which shows that I'm board certified dermatologist. Oh, okay. So disclosures, I have no conflicts of interest to disclose. And objectives, we're going to go through the day-to-day of the specialty of dermatology. We'll go through how long really a dermatology training is, if there's fellowships involved, and so forth. And then we'll wrap it up with some clinical cases. All right. So first, I'm going to just start with a typical day as a dermatologist. Of course, it depends on what type of dermatologist you are. So there are actually multiple types of dermatologists. You can be what's known as, probably by most people, a medical dermatologist who sees patients in the office and sees patients of all ages. So that would range from pediatric all the way to geriatric. Then there are specific pediatric dermatologists who will only see pediatric patients or children. We have Mohs surgeons. And Mohs is a type of skin cancer surgery. It's Mohs micrographic surgery. And basically, a Mohs surgeon is someone who is trained in treating skin cancers. And this is a very special technique where the skin cancer is removed in stages. And the same surgeon is also trained in looking at the specimens under the microscope to determine whether there's any cancer cells still remaining. There's also dermatopathologists. So these physicians are doctors who are dermatologists, but also have additional training in pathology, so they can read slides, specifically biopsies from skin. And we have cosmetic and laser dermatologists who may only, let's say, specialize in cosmetic and laser procedures. So again, the typical day depends on what type of dermatologist you are. I would say that most dermatologists practice a combination of medical, surgical, cosmetic, and laser dermatology. So that's one of the fantastic parts about derm is there's a lot of variety, which entails seeing patients for medical visits, for skin checks, for acute visits, being able to do your own surgeries, and then also being able to engage in some cosmetics and lasers. So again, to my point, a variety of patients and procedures, all in an outpatient setting for the most part. There is part of dermatology that is developing now more as an inpatient dermatologist, someone who does consults at the hospital as well. But typically a dermatologist is going to see patients in the office. You know, for me personally, my day starts around 8:15. That's when my first patient is scheduled. And I have patients every 15 minutes throughout the day. Apart from my lunch break, and usually my last patient's at 4 p.m. And as an attending now, I do work 4 days a week. And interestingly, as a dermatologist, there is perhaps some call or hospital call involved. I personally work in a private practice, but prior to working in the private practice that I'm at, I was in an academic department. And when I was in an academic department, even as an attending, I did have call, which meant I did have to cover the hospital consults. So that those are patients who are hospitalized, maybe for other reasons, but then happen to have a dermatologic emergency or a skin issue that's more urgent and needs to be seen at the hospital. And so, depending on the practice that you're at, you may actually have to cover call or hospital call. Call may also mean that you have to cover patient phone calls. So just after hour emergencies, let's say from surgeries and so forth. And as a dermatologist, I would say typically you see patients every 15 minutes in clinic. Obviously, some patients, patient visits take much longer than this. Some patient visits are shorter than this, but this is how we're scheduled. And then, depending on the way your days are divided, you may have a surgical day. For me, for example, on Wednesday afternoons, I do mostly all my surgical excisions, which means I'm taking out skin cancers. I am taking out cysts, maybe lipomas, which are fatty tumors. And then I do have a cosmetic day. So these are the days, or laser day too. These are the days where I may do more cosmetic procedures. So this would entail injectables, like toxins and fillers, and then lasers, which we do for a variety of reasons. So there's a lot of different things or components to my day. I love my procedures, which also I should say dermatologists do a lot of small procedures like biopsies. But I really think at the end of the day, my favorite kind of visit is a visit where I've seen a patient for a rash that, let's say, they've gone to other doctors for who didn't know what it was. And I've biopsied it. I've gotten a diagnosis. We've discussed therapy, and I put them on a medication which has totally cleared their rash and changed their life. So for me, that's actually the most fulfilling type of visit. So, oh, and of course, we have lunch in the middle of the day. At the end of the day, a lot of times I'm reviewing my biopsies. So these are, again, are biopsies of skin that I have done on my patients. I get the results back. I'm looking at the results and following up with my patients if they have a skin cancer, let's say a melanoma, returning patient calls, and just wrapping up my charts through the electronic medical record system. All right, so dermatology training. So this is basically, what it takes to be a dermatologist after medical school. So after 4 years of medical school, we start our residency. And for dermatology, we have to match into both a 1-year preliminary residency. So you can think of this 1 year as sort of like a general residency. And then the dermatology residency itself is 3 years. Okay, here we go. So in essence, dermatology training, dermatology residency training is 4 years total. This first year can be in internal medicine. That's personally what I did. I did what's called a preliminary internal medicine year. It could actually be done in general pediatrics. It could be done in general surgery, or there is such thing as a transitional year residency where you kind of get a little taste of all different specialties. And then you have 3 years of actual dermatology residency. You do take your dermatology boards exam to be a board certified dermatologist at the end of residency. Typically, this is in July after your last year of residency. And then I also just wanted to mention that even after dermatology residency, although dermatology is a highly specialized field, a lot of residents choose to pursue a fellowship. So by and large, I would say most dermatology fellowships are 1 year. And the fellowships that are most common are Mohs surgery, where you can become a Mohs surgeon, which I discussed at the beginning. You could do 1 year of pediatric dermatology fellowship. You could do a year of dermatopathology, where you can read slides. And recently, I would say in the past 5 to 10 years, there's more cosmetic dermatology and laser surgery fellowships. Some of these subspecialties require additional board certification, so you may end up taking additional boards to be board certified. Let's go back. Oh, and then another thing I wanted to mention, continuing medical education requirements. So beyond residency, you're always going to be responsible for getting more CME credits. This is part of being a lifelong learner. And then every 10 years, you are expected to take your board's exam to be recertified. There are some other American Board of Dermatology requirements as well. I would say that when you are in private practice and practicing as a general dermatologist, you are going to see a lot of full skin checks. So these are patients who are coming in to get their entire body scanned for skin cancers. While they come in for, maybe this one thing, the full skin check, they may have other issues. So they may have, let's say, eczema or atopic dermatitis. They may have psoriasis. They may have lupus, and you may address these issues in these visits as well. So I would probably say the majority is going to be full skin checks, where you're basically doing a surveillance and screening for skin cancers. And then biopsying any, specimens or moles, let's say, or growths that seem suspicious. And then the other majority or part of what I would see mostly is rashes or chronic skin problems. Just like we mentioned, things like eczema, psoriasis, acne are the most common things. So I chose cases that are very much bread and butter dermatology. And you may not feel, or some people may think that there's not too much to these types of diagnoses, but I figured they would be valuable in sort of getting a taste into derm. So here are just some photos of some patients. And I would say probably most people would look at this and say, and these are pictures of the face, of course, okay, this looks like pimples. And that is right. This is just non-inflammatory or comedonal acne. And I'm going to flash some other photos. Again, some acne. This looks angrier. I think most of us could agree, the pustules, the redness, just a lot of erythema. So this becomes inflammatory acne. And so inflammatory acne is made up of papules and pustules. So in dermatology, we have a lot of terms basically describing morphology of skin lesions. So that's really important to us in dermatology. Inflammatory acne is made of nodules and cysts. It can result in scarring, post-inflammatory hyperpigmentation. So that's a type of scarring, essentially, where you hyperpigment. And then what's important to know with acne is there's different types of it. So like I showed, there's inflammatory acne, there's non-inflammatory acne, there's even acne that causes fevers and joint pain. And this is this last bullet point here, acne conglobata. It's a severe form of nodulocystic acne that presents as really, really inflamed acne along with joint pain in the knees, the back, maybe the elbows, and then fever as well. And this is, again, inflammatory acne. Let's go back. You can just kind of see, obviously, this other picture here on the right is scarring acne. And then there's a lot of other subtypes of acne, like I mentioned. There's acne fulminans, which is a type of inflammatory acne, and like the one that we talked about with fever and systemic symptoms. There's interestingly something called acne excoriae. It has its own diagnosis, and this is even thought of as more of a psychological condition. What some people may not know about dermatology is there's a huge psychological component of it into its diseases as well. But this is when patients actually pick at all of their acne lesions. And then there's acne in adult women, which looks different than typical teenage acne or some of the acne that we saw. And I'll show some photos of that as well. So this one actually is these are photos of acne fulminans or acne conglobata, which is, again, extremely, angry acne, very inflamed, huge pustules and sinus tracts. It almost exclusively affects males, particularly young males. And again, they're going to have systemic symptoms. So that means they're going to have symptoms like fever and joint pain. So we treat this with steroids to calm everything down. And then also with a type of acne treatment, something known as Accutane or isotretinoin. All right. So these are females. And, we talked about acne excoriae. You can see every single little lesion on their faces is picked at. So this is acne excoriae. It also has a French name, acne excoriae des jeunes filles, which just means excoriated acne of young females. And when you talk to these patients, they don't want to pick at their acne. It's just a habit that has formed. And a lot of time there may be some underlying anxiety involved. And it is a really, really tough habit to break. but very satisfying if you can get these patients clear. So this requires a lot of counseling with patients, a lot of talking. Sometimes we even have to get, cognitive behavioral therapists involved or psychologists involved to sort of address the picking part of it. While as dermatologists, we try to clear their skin of the acne so there's no more lesions for them to pick at. All right. And so here are some female patients with acne all along the jawline. And what this is basically post-adolescent acne or acne in adult women. So there really is another entity of acne in women who are about 25 and older, who basically present with maybe never had acne as teenagers, maybe they did, but then in their adult years just have really inflamed, sort of deep-rooted, deep-seated nodules around their jawline. We think maybe this could be due to some androgen excess. So that's excess of certain hormones like testosterone. These patients sometimes also present with something called hirsutism, so increased hair growth on the face. And sometimes they may actually have polycystic ovarian syndrome. So they may have irregular periods and cysts in their ovaries. And so this also becomes involves sort of addressing the acne, not just the acne component, but the part of the disease, which is the androgen excess. So we'll oftentimes treat this type of acne with anti-androgens. So those can be oral contraceptive pills or a medication known as spironolactone, which is a diuretic, but also helps control testosterone or hormone levels. All right. So, my point with this is, a lot of times you think of dermatologists and you think of pimple poppers and just acne and that's all they're doing. But as you can see, there's a lot of different components to acne. And for many dermatologists, it's one of their favorite diseases to treat because number one, it's so satisfying to have a patient clear of acne. Number two, honestly, acne has a huge impact on quality of life. So to be able to get patients clear is very satisfying. And then number three, there's just a lot of different tools we have in our toolbox. So it's important for the acne to be addressed in the right way. So when you see a patient with acne, sometimes you can be fooled. So there actually maybe, bumps are not always just acne. So there could be something like molluscum, which is basically spread through a virus. It looks like pink flesh-colored papules or bumps on the body. Other adnexal tumors. So adnexal means tumors that derive from either, hair follicles, basically, or glands. So those can look like pimples because they just kind of look pink and bland. Sometimes it can be folliculitis, which is just inflammation of hair follicles. You want to ask the patient about their history. Are they male or female? How old are they? What is their occupation? Let's say they're sweating a lot. Or, these days we talk about maskne all the time because it truly is a thing, right? And that has its own diagnosis too. That's just mechanical acne, which is basically acne due to the mechanical rubbing of something on the face. You want to ask them about their skincare habits, their desire for treatment, how aggressive do they want to be? Are they looking to be totally clear? Do they want to take pills? Do they want to take more of a natural route? Family history of acne is also important. And then we go on to the physical examination. So we're looking at the skin type of the patient, which really means their pigmentation. We have fair patients all the way to darker skinned patients, and acne presents in different ways and scars in different ways in these different patients. Is their skin type oily? Is it dry? What are their lesions like? Are they scarring? Where's the distribution? Is it just their face? Is it their face, their chest and back? Hirsutism is the increased hair growth that we talked about. Is there a deep voice involved, which would then again indicate more of a hormonal component, and then the severity of acne, which is rated really mild, moderate, and severe. So treatment modalities for acne. So we obviously have topicals, which are going to be creams and washes. Things like topical retinoids. So everyone, a lot of people hear about retinols in the media. Topical antimicrobial. So these are things like benzoyl peroxide, clindamycin. Oral antibiotics, but we really use this more short term. These days, this was something that dermatologists may have used long-term many years ago, but what we know about antibiotics is they do change the good gut flora in your intestines. So it's really just used as a temporary Band-Aid, and we want to take you off of it quickly if you're on an antibiotic. Oral contraceptive pills are FDA approved for acne. Spironolactone, as I mentioned, it's a diuretic. This is actually not FDA approved for acne, but is used extremely commonly off-label for acne in adult women. Oral isotretinoin, so this is a type of synthetic vitamin A. It's also known as Accutane, and that's really our magic bullet for acne that gives us a cure, or the best chance of cure. There's light-based therapies, so we might do things like blue light or red light. We can do chemical peels, and of course, patient education is really important because whatever we do, there's always a routine involved, so spending lots of time with your patients so they're really clear on their routine. So we'll run through this quickly, but basically mild acne, you'll start with a topical, maybe a topical retinol, then a topical antibiotic. You might throw in some chemical peels. Treatment of moderate acne, usually we'll do the oral antibiotic short term with a retinoid. Second line, an antibiotic with a retinoid. Other topicals like azelaic acid. And if someone's scarring, we'll start to have that conversation about Accutane or isotretinoin. For female patients, we'll think about birth control pills, so oral contraceptive pills plus or minus spironolactone. And then these are just, for anyone who's interested, we've got different oral contraceptive pills which do have the FDA approval for acne. And then spironolactone dosing, and then of course oral isotretinoin, which I called the magic bullet because it really is meant to cure patients of acne. If they go through a course of oral isotretinoin, I would say 70% of patients don't get acne again, 30% do. What do we do in that case? A lot of times they'll do 2 or 3 courses of isotretinoin. And then treatment of moderate to severe acne, really we're talking about oral isotretinoin. Here, there's some other orals that we can sometimes use. We may inject their big pimples too. That's intralesional Kenalog on the right. I'll show another picture here, but this is an extremity of a patient, again, with these really well demarcated erythematous pink plaques with silvery scale. And so this is psoriasis, which is huge these days because there's so many commercials about all the therapies involved and biologics that you can use along with all of their crazy side effects. But this is the typical type of psoriasis that we know of and that we commonly see. It's called chronic plaque type psoriasis. And then, excuse me one moment. Okay. So chronic plaque type psoriasis presents as relatively symmetric erythematous, which means pink or red, scaly plaque. So when I say symmetric, I mean mostly both sides, right? So you're going to find it on both elbows, let's say both knees, behind both ears, okay? Not usually on one side or the other. That's not impossible, but not usually. Most common type of psoriasis. For 45% of patients, the genitalia is involved. So it could be in their buttocks, it could be in the front side, but this is an important area to address too. And the plaques, unfortunately, they can persist for months to years, and they can get worse and worse. So it can be a progressive disease. And we do have this rating scale to help us figure out whether a patient is eligible for a medication, such as a biologic medication, which would mean injections. It's known as the Psoriasis Area and Severity Index. A lot of times these are used in articles and clinical trials of psoriasis as well. And we'll get to the treatment of psoriasis because that's a really important topic too. And one thing that I didn't put in the slides, but psoriasis does seem to affect adults more commonly. We do have pediatric or childhood psoriasis as well. But seems to kind of affect middle age, I'd say, men and women. And another thing interesting about psoriasis is it does seem to have associations with basically metabolic syndrome. So that means diabetes, hypertension, high blood pressure, cardiovascular disease. So once a patient is diagnosed with psoriasis, we'll often write a letter to their primary care or give their primary care doctor a phone call just to make sure these patients are screened for these other routine things as well. Okay, so this, these are two pictures. Now you see these tiny, tiny, tiny little pink papules with silvery scale. So kind of similar to what we saw, but now so many more of them and so much smaller. And this is another form of psoriasis. This is interestingly called Guttate psoriasis. So it looks different. And I actually get a lot of referrals from other doctors, like primary care doctors, who are not sure what this is, let's say, or even I would say more so maybe urgent care, where they think maybe it's an allergic reaction. But for dermatologists, we can recognize this as Guttate psoriasis because it's treated differently as well. So guttate psoriasis, it's really uncommon in adults. We see it much more commonly in children and adolescents and in young adults, I would say. And over half of these patients, they have these elevated ASO titers. So really what that means is a lot of times what happens to these patients is they have a strep throat infection or other type of strep infection. And then interestingly, they present with this rash. Sometimes it doesn't have to be necessarily a strep throat infection. It can be some other virus, but oftentimes the history will be that they had a strep throat infection, and then all of a sudden their strep throat was fine after they took antibiotics, let's say, but then they presented with this rash as well. And then let's see, I think I've got one more bullet here. Okay, so it can clear spontaneously in weeks to months. So unlike chronic plaque psoriasis, which really persists, guttate psoriasis may just go away completely on its own. But oftentimes if they're coming to see us or coming to see the dermatologist, it hasn't gone away. And we usually end up doing NB-UVB as narrowband UVB light treatment. So this is UV light treatment. We have these light boxes. Patients come in, let's say 2 to 3 times a week for up to 6 weeks or minimum of 6 weeks up to a few months for narrowband UV light treatment. And this can suppress their immune system and clear them of their skin. So unlike chronic plaque psoriasis, where we really think the patients are going to be dealing with it lifelong, guttate psoriasis we expect to clear up. All right, so in summary, finally we're at the end. Dermatology is awesome. Obviously, I'm biased since I'm a dermatologist, but I think there's a lot of amazing components to dermatology. And while it can be really competitive to get into, it's 100% worth it. And it's definitely worth taking the time, like we discussed today, to achieve that goal if that's something that you want to do. We have incredible breadth and depth of disease and patient variety, which I think is actually important to know, because a lot of times you think like there's not much to skin, but there's so much to skin. There's so many different diseases. I just touched on acne and psoriasis, but we have skin cancers, we have other autoimmune disorders, we have procedures we can do. There's just a lot of different things. And then you see patients from infant all the way to like 100-year-olds. So it's really neat in that way. These are just my resources, and this is just a wrap up of my presentation.